My topic for presentation today is neurogenic bladder, and it is an important topic as far as the PG students are concerned. So I want to start with declaration that this is an overview and not at all a complete picture on this topic, because picture is changing frequently, evolving, improving, becoming more precise, specific, and sensitive with the introduction of new methods of assessment and interventions. And most of the times you must have seen, or almost always seen, there is no conflict of interest. But I have to declare a conflict of interest. The purpose of making presentation is I want that students should perform well. And that is the conflict that I have. I love them, I like them, I want them to improve their performance. And that is why, as faculty, we make efforts to transfer some of the knowledge and to encourage them to read on their own. Because postgraduate level teaching is not didactic, it is not pedagogy, it is andragogy. My main objective, as I have told, it is to encourage and guide the PG students. What is important to know about this topic and why it is important to know. And they should not stop once they pass the exams. Learning should be a habit, a continuous process, and it should be a matter of joy. And I also keep learning despite becoming the professor and head of the department, because sometimes I have realized the students know many things, much more, or latest things, and I am spending a lot of my time sanctioning some leaves, stopping some leaves, etc. So I will try to cover the topic through some questions, because I have realized that if the students are asked questions, then their brain starts ticking. Then they will try and look for the answers. And that is what I am going to attempt now. Now, first of all, why it is important to know about this topic of neurogenic bladder. This should be the first question in the mind of residents. The first and foremost, it is very often asked in the examination. And your immediate goal is to clear the examination successfully. So invariably, you will come across a short note, or sometimes if you get a long question centering around spinal cord injury or stroke or certain other disorders which lead to neurological impairments, you are expected, for the sake of complete answer, not to ignore this bladder management aspect. So very important from the student's point of view. And once you are successfully cleared of the examination, then you are a senior resident and there subsequently the faculty member. You will be closely and deeply involved in the assessment and management of people with neurogenic bladder. So there are a few important questions. Why it is important to know about this? What is this? That means what is the commonly used definition of neurogenic bladder? When does it occur? What are the manifestations? What is the pathogenesis? What are the different types, or in a way, what are the classification systems of neurogenic bladder? What are the investigations required for diagnosis? Because there are more than one type of neurogenic bladders. What is the kind of management that is feasible in a PMR setup? Because you should not forget the reality that the management will be different in a urology department. The management of neurogenic bladder may be different in a gynecology department. And if you are a resource-constrained setup, then how will you manage people with neurogenic bladder? Because every institution, or rather majority of institutions in the country, even at the medical college, hospital level, do not have urodynamic setups. It is very expensive. So you should still be able to evaluate rationally and make a proper plan for the management of the person with neurogenic bladder. And you should be able to refer the person to the right center or the department as and when the need arises. So always give hope to the person who is suffering from neurogenic bladder knowing fully well that most of the times there is no cure. But whatever cannot be cured must be endured, and it should be endured with hope and knowledge. You should know what are the common outcomes in this clinical scenario. So, how is neurogenic bladder defined? There are many definitions, but so far in the literature, there is no single definition which is attributed to a professional association. But as per the common understanding, a bladder is considered neurogenic if there are impairments in function that result from abnormalities in the peripheral or central nervous system. Voluntary control problems include sensory problems, inability to perceive bladder fullness, inability to voluntarily initiate micturition, and incontinence. The result is urinary retention and or incontinence. And when we talk of the neural control of the urinary bladder, it is very important in a very simple way to remember that sympathetics are critically involved in storage and parasympathetics facilitate peeing. The term neurogenic bladder refers to organ level dysfunction or an impairment that results from central or peripheral nervous system damage. The pelvic parasympathetic nerves S2 to S4 innervate the detrusor muscle, which is in the bladder wall, with motor and sensory fibers. And out of these S2 to S4, S3 is usually the major nerve. The somatic mixed pudendal nerve, which is S2 to S4 again, includes motor and sensory fibers, and it innervates the pelvic floor, which includes the external anal sphincter. S2 is the key nerve in this. Very often you will read or hear the term detrusor sphincter dyssynergia, and many times a short note is asked on this topic only instead of the entire neurogenic bladder. So it is the simultaneous contraction of the detrusor bladder wall and external anal sphincter or pelvic floor, which generates excessive bladder pressure to the tune of more than 50 centimeters of water. Normally, when the detrusor contracts, the sphincter relaxes. This is how the urine comes out. Detrusor sphincter dyssynergia occurs with lesions of the spinal cord above the conus medullaris. Persistent high pressure voiding with pressures beyond 50 centimeters of water is associated with back pressure changes, leading to hydronephrosis and deterioration of the renal function over the years. And that is why it is important to periodically evaluate the persons with spinal cord injury or stroke with respect to involvement of the bladder. Supraconal bladder dysfunction is associated with bilateral paralysis of toe movements, hyperreflexic phase stretch reflexes of the gastrosoleus muscles, and positive bulbocavernosus and anocutaneous reflexes. So that is why it is important to take detailed history to know what is the voiding pattern in the person now after an injury or after an illness in comparison to what it used to be earlier. And also detailed clinical examination to know what are the neurological deficits in the person. These days we can do bedside ultrasonic assessment of the person. You can ask the person or help the person to fill up the bladder and then measure the capacity of the urinary bladder. Also, you can do what is the residual volume of urine after emptying the bladder. Because this has a bearing, if there is too much of urine which remains in the bladder after voiding, it leads to many problems, and first and foremost among which is urinary tract infection. Stasis. Stasis leads to calculi formation. If there is obstruction in the bladder outlet, it can lead to back pressure, development of trabeculae in the wall of the urinary bladder, and hydroureter, hydronephrosis, etc. Many times you should realize that if the person is 50 years or above, there may be associated enlargement of the prostate gland also. So never ignore the existence or possibility of more than one pathologies in the same individual. So that is why it is important to evaluate the person in detail from multi-system involvement point of view. This is a diagram to represent what is the relationship between the detrusor, and the sphincter. The dotted lines indicate underactivity. The dark black colored lines indicate strong either wall or contractions. In the first, here you can see there is overactive detrusor, dark thick black circle. This is detrusor which is overactive, and the sphincter is also dark and thick colored, overactive sphincter. You can imagine what will be the state of affairs of the urinary bladder. In comparison to this, here it is overactive detrusor, but the sphincter is normal. Third diagram, normal detrusor, but dotted line indicates underactive sphincter. Here it is underactive detrusor, overactive sphincter. So urine will be collected in the bladder because sphincter is overactive. It will not allow the urine to pass out easily, and the bladder is likely to get distended. Here normal detrusor, overactive sphincter. Overactive detrusor, underactive sphincter. And likewise underactive detrusor, normal sphincter. So all these 8 different types of permutations and combinations are possible in different individuals. And on top of that, there is incoordination between the contraction of the detrusor with respect to relaxation of the sphincter. This is another diagrammatic representation, because when you are asked in the examination, if your answer is supplemented by suitable, appropriate, neat and well-labeled diagrams, you are likely to fetch more marks. You will yourself also be happy. So here you can see suprapontine lesions. So there is a history with predominantly storage symptoms. Ultrasound examination of the bladder area will show insignificant post-voidal residual urine volume, and urodynamic assessment will indicate detrusor overactivity. In the spinal infrapontine suprasacral lesions, this will be the history, both storage and voiding problems. Ultrasound will show post-void residual urine volume, usually raised. Urodynamic evaluation will indicate detrusor overactivity, detrusor sphincter dyssynergia. And sacral or infrasacral lesions, the history is usually predominantly of voiding symptoms. Ultrasound may show post-voidal residual urine volume raised, urodynamic evaluation, hypocontractile or acontractile detrusor. Now, CISC, although considered as the gold standard of assisted bladder drainage mechanism, has several limitations that treating physicians should know carefully, and they should assess and adjust those limitations if possible, or shift the patient to alternate drainage options. Never close your mind to the fact that options better than clean, continuous or intermittent catheterization is also possible. The frequency of CISC depends on many factors such as fluid intake, bladder volume, urodynamic parameters, etc. And it is generally recommended to be done 4 to 6 times daily. Now, suprapubic catheters I have not seen being used much in PMR settings, but they are in many situations better than urinary catheters, urethral catheters. They have a few advantages over urethral catheters, and these include elimination of the risk of urethral erosions, elimination of the risk of iatrogenic hypospadias, lesser risk of epididymitis or orchitis. It allows patients to perform sexual activities, and there may be a decreased risk of urinary tract infections with suprapubic catheters. Now coming to urodynamic studies, sometimes there is short note on that also. Or as a part of the long answer, you have to mention 4 to 6 lines about urodynamic assessment also. Now, urodynamic evaluation is the cornerstone in the evaluation of lower urinary tract dysfunction in spinal cord injury patients and many other categories of patients. But its technique and timings are essential, and it is a very resource demanding setup. It requires training also. Many small setups are not able to procure it and manage it. That is why it is better that PMR departments work in collaboration with the departments of urologies, because most of the large medical college hospitals have these departments. Several urological authorities and guidelines recommend performing the first urodynamic study 3 to 6 months after the spinal cord injury, as recent evidence has shown that adverse urodynamic parameters can appear as early as 40 days after the spinal cord injury. That is about 6 weeks after the onset of, once the person is almost out of the spinal shock. Video urodynamics, if available, is considered as the gold standard in the evaluation of patients after spinal cord injury, as it can detect vesico-ureteric reflux and unmask hidden low bladder capacity and low compliance in patients with vesico-ureteric reflux. There have been many publications in the last 15 years. People are becoming more evidence-based driven, and they are developing guidelines, and they are also testing the strength of evidence for various recommendations. And this is one of the recent publications in which there was evaluation and management of neurogenic bladder after spinal cord injury, current practice among the physical medicine and rehabilitation specialists in Turkey. And this is a well-written article. I will suggest the residents to read it. They concluded in their study that results of the study indicate that there are some differences in the current practice of PMR specialists for surveillance and management of spinal cord injury patients with neurogenic bladder dysfunction. Although treatment regimes may be individualized in response to each patient's individual needs, the results emphasize the need for development of guidelines and implementation of continuous medical education activities in this field, and this refresher course is serving one of such purposes. Limitations of CISC include limited upper extremity motor function due to tetraplegia, and also in patients who have visual impairments or those who are blind. Anatomic limitations such as inability to reach urethra due to marked obesity or in female patients. Limited functional bladder capacity, that is below 300 ml, such as poor bladder compliance or untreated NDO. NDO means neurogenic detrusor overactivity. Obstructed urethra, for example, severe urethral damage, urethral stricture, non-relaxing sphincter. Screening cystoscopy is very important, and I am aware that many PMR specialists are very comfortable and they have acquired the skill of doing the cystoscopy, and that is a very good thing. So younger residents also should develop interest, and under the mentorship of trained physiatrists who are regularly practicing this. I think Dr. Mrinal Joshi and CMC Vellore and a few other centers are active in this. It should be kept in mind that indwelling catheters, urethral or suprapubic, they are associated with increased risk of bladder cancer to the extent of 10% in the long term. Therefore, screening cystoscopy has been recommended to start 10 years after the indwelling catheter insertion. In cases of increased urethral leakage, recurrent urinary tract infections, or increased sediments and frequent catheter blockages because of these sediments, cystoscopy is recommended to rule out the presence of bladder stones. So these are the two definite situations where it has a role to play. Now this is a tabular depiction of overview of management approach to neurogenic bladder. There are some management lines in the sense that assisted bladder drainage. And what are the options? Clean intermittent self-catheterization, including suprapubic catheters, indwelling urethral catheters. Systemic medications to reduce the intravesical pressures, such as anticholinergics, beta-3 agonists. Intradetrusal botulinum toxin A injections, these are the agents that are available. Sacral nerve stimulation, there is not much experience in India, but it has a significant role in certain situations. Surgical treatments such as bladder augmentation and urinary diversions are some of the techniques available. So systemic medications to treat neurogenic detrusor overactivity are sometimes used in day-to-day PMR practice while dealing with patients with spinal cord injury with neurogenic bladder. Systemic medications have been used to reduce detrusor storage pressures, increase bladder capacity, and improve the urinary incontinence. The most commonly used medications are anticholinergics, antimuscarinics, and beta-3 agonists. And options for pharmacological manipulation of bladder function are outlined in the next slide in the table. So here you can see what is the desired functional change that you want to have. Improve bladder emptying facilitates bladder contraction, that is muscarinic action. Drug is bethanacol, clinically used. Here are the mode of action. If the purpose desired is decrease the outlet resistance, these are the drugs that are available. Many of these are used. And this is the mode of action or mechanism of action. If the purpose is reduce bladder contraction, that is increase the outlet resistance, then atropine and other agents can be used. If the purpose is improve the bladder storage and increase the outlet resistance, then tricyclic antidepressants. Now, many of these medications have their own limit to efficacy and duration for onset of action and some side effects. So, oxybutynin and tolterodine are the anticholinergics available to manage detrusor hyperreflexia, and most of the autonomic drugs that change anterior tone also seem to have the effect on the bladder neck. That is, alpha agonists, they constrict the bladder neck, and alpha blockers relax the bladder neck. And it is important to remember that in the human bladder, detrusor muscle, there are muscarinic receptors M2 and M3, and M3 receptors compared to the M2 are small in number, but are mainly responsible for bladder contraction. And this is the diagrammatic representation of distribution of muscarinic and beta-3 adrenergic and alpha-1 adrenergic receptors in different areas of the urinary bladder and urethra. Antimuscarinic drugs, oxybutynin, tolterodine, derifenacin, solifenacin, and trospium chloride are the 5 major drugs currently available to manage detrusor sphincter hyperreflexia and to help reduce bladder voiding pressures. Comparative clinical studies have shown that oxybutynin and solifenacin may be marginally more effective than tolterodine, although the latter seems to be better tolerated. So you have to see efficacy versus tolerance to a particular chemical agent. And also the factor of cost becomes important. Dry mouth and constipation are still the major problems for the patient compliance with all of them because of widespread existence of M3 receptors, particularly in the salivary glands. Systemic medications along with CISC constitute often the first line management. Follow-up after starting the systemic medication is generally warranted, which includes follow-up of symptom improvement and urodynamic study in 3 months or later. Now, these drugs should be avoided in patients with glaucoma, myasthenia gravis, GIT obstruction, and severe ulcerative colitis. Now, beta-3 agonists like mirabegron, the commercially available beta-3 agonist to treat detrusor overactivity, has been introduced recently. It acts on beta-3 receptors on the detrusor muscle to induce relaxation of the detrusor. Its use in NDO has been shown to increase the volume of the first detrusor contraction and to improve bladder compliance. The usual dose is 25 to 50 mg per day, which can be increased to 100 mg per day as tolerated. Now, the positive adverse reactions include hypertension, urinary tract infection, and headache. So, these become the limiting side effects in some patients. The use of mirabegron is currently limited in neurogenic bladder patients, as limited evidence exists to support its use in this population. It might be considered in certain situations, such as an alternative in the patients with contraindication to using anticholinergics or as an add-on treatment to anticholinergics. Now, intravesical injection of botulinum toxin is also tried in some situations. Botox injection is a neurotoxin, you all know, for management of focal spasticity. It has been approved as a treatment for neurogenic detrusor overactivity since 2011. Now, the usual dose is 200 units. Earlier it was up to 300 units. It has been reduced now. Injected into detrusor muscle in 20 sites, delivered via cystoscope. It increases the bladder capacity, reduces maximal detrusor pressure, and reduces urinary incontinence episodes in comparison to placebos. It also improves the bladder compliance and reduced incidence of detrusor overactivity. But the effect tapers off and disappears after a few months. On an average, 6 to 7 months is the effect that lasts. But it can be repeated again. This is the diagrammatic representation of the spots where the Botox injections are given. The possible common adverse effects include urinary tract infections, hematuria, generalized weakness, and urinary retention. But this is not generally a concern in patients with CISC. The effect, as I told you, usually lasts for a few months. Other measures include behavioral changes, timed voiding, pelvic floor exercises, and transcutaneous electrical nerve stimulation. And these have all been found in some studies to be effective. So there is an armamentarium of interventions that can be tried depending upon the needs of individual patient and the resources available in the individual departments, specific departments. So what are the common urinary tract complications? Just a few minutes more I'll take. What are the common urinary tract complications of neurogenic bladder? The earliest changes in the bladder are noticed as trabeculations seen inside the bladder wall, as irregular thickened bladder wall, and even small diverticuli seen on voiding cystographic studies. Vesico-ureteral reflux has been recorded in 10 to 30% of the poorly managed patients. The presence of reflux is a serious complication because it leads to pyelonephritis and renal stone diseases. Severe bladder outflow obstruction can result in bilateral hydronephrosis and hydroureters, and even an overdistended areflexic bladder. Many years ago, or for the last many years, bladder complications were the leading cause of death. In certain studies, these are the respiratory infections in tetraplegics, and in certain studies now, infected long-standing pressure sores are also the important. So these are the three important killers in persons with spinal cord injury and neurogenic bladder. The other emergency situation being autonomic dysreflexia if it is not picked up early and managed promptly. Repeated bladder infections is another complication. Perhaps the last question in the mind of resident doctors may be, what books should we read for this topic? Is it true, or my assessment is very wrong and faulty? Because if you see around, there are many books which are available. So do not read or run after many books. This is a common mistake which many residents make. Try and understand what you are reading. Because many a times later on the students confide कि सर मुझे आंसर आता तो था पर उस समय याद नहीं आया, मैंने पढ़ा था. So never have that kind of embarrassment कि आपने पढ़ा तो है लेकिन जब एग्जाम में सवाल पूछा गया तो आपको याद नहीं आया. You are not able to recall. This is because of high level of anxiety and poor quality or poor quantity of sleep before the exams. You are reading too much, or you are eating too much, biting too much, but not digesting it well. Never make that mistake. Try to develop habits and read properly many months before the final examination. Start with the basics and build further on it. Try to correlate what you are reading with the real life situations and needs of the patients. Don't read in isolation without any thought about the application of what you are reading. And besides the book, learn from articles published in reputed journals, the recommendations and the guidelines, online resources, and most importantly from the patients. And I'm glad that you are attending such academic events as the refresher course. This is also a very important way of learning. This is just for reference some of the standard books which I recommend to the students. Bradham's Physical Medicine and Rehabilitation. This is the latest edition cover. In that, chapter 20 deals with neurogenic lower urinary tract dysfunction or neurogenic bladder. Go through this. It is a very well written, quite comprehensive chapter. The other standard book is D. Lisa's Physical Medicine and Rehabilitation, latest edition. This also has a full chapter devoted to this. Another popular book I have seen with the residents is Physical Medicine and Rehabilitation Board Review. This also gives, in simple format, point-wise, good information, and there is a lot of information about neurogenic bladder in this book also. And the latest addition to the armamentarium is the IAPMR textbook of Physical Medicine and Rehabilitation. Please go through this also, and if possible, have it in your collection of books. So to conclude, Every patient with neurogenic bladder needs to be evaluated by following the standard, traditional, time-tested approach, beginning with history taking, proper, meticulous, systematic clinical examination, which will help you in deciding what are the investigations that are relevant to the individual patient and within the resources available. If you are resource poor and if you don't have the ultrasound machine in your department, there is no point running after the urodynamic apparatus. Okay? And whatever instruments you want to have, you will have to spend some time to learn the use of those instruments and interpret the reports of that. For example, if you subject the patient to urodynamic evaluation, do you have the skills to interpret the urodynamic report? That is very important. And expertise which is available, because the reports will have to be followed by appropriate interventions. So you have to be building capacity in terms of interventions that you can offer to the patient to relieve the symptoms and signs. Every patient with neurogenic bladder need not be subjected to urodynamic evaluation. Teamwork matters. Join hands with urologists and gynecologists, and every patient should be given hope as he can be improved with respect to quality of life, if not in terms of cure of the condition. Thank you so much. I think I have taken a few minutes more than allowed.
So one question.
Yes, please.
Like if we are starting the patient on CIC, so if patient is asymptomatic bacteria, should we start antibiotic or not? This is my common we encounter in the wards patient like.
Decision for antibiotic administration should not be based upon the lab report only. You have to see what is the symptom which the person is having. Whether the person is otherwise healthy, not looking ill, even if there is no fever, no chills and rigors, but you suspect that there is a high possibility that the person will be having some infection. So immediately rushing to start antibiotics is not the recommendation. You improve the level of hydration, you ensure that the person is regularly voiding, you observe the color and smell of the urine, and then decide whether there is a need. Indiscriminate use of antibiotics is one of the major factors responsible for antibiotic resistance among the microorganisms.
So like we are using for CIC, patient putting on CIC. So at
Yes.
that time, should we start or not? If
If the steps followed are proper while doing the CIC, if the catheter is kept properly in a proper recommended way, if the insertion is proper, if the urine that is being drained is being seen, it is clear, there is no need for antibiotic administration in CIC. There are many situations, like yesterday I was listening to one of the presentations, the routine administration of antibiotics for any surgical intervention is also discouraged. Sometimes one of the speakers presented
regarding the pressure,
पानी से साफ कर दो, बीटाडीन की जरूरत नहीं है. That is also very effective. So let us reduce the indiscriminate use of antibiotics. Thank you.